Plastic surgery patients are still confused about all of the information and misinformation out there online, social media, and that's why we have No Spin Live, and we've got these three great international plastic surgeons to share their views on hot topics in plastic surgery. We got Dr. Jason Poser from Boca Raton, Florida. This is all Florida No Spin. We've got Dr. Anup Patel from Orlando, and last but not least, Charlie Mesa from Weston, Florida. So the Florida gang is here. What do you say, guys?
How's it going? Good to see you, Bill.
Nice weather here. That's all I can say.
You guys, it's cold here in Dallas, so I'm going to come visit you guys. Listen, we've got a new thing for No Spin. Jason's going to introduce it. We always get these emails from patients who want us to discuss cases and what we would do in certain situations. So, Jason, you brought a case. Tell us about this.
And it's also the question is, many times before we get on No Spin, we're sitting here talking about cases and what we would do in certain situations. So we thought we would be good to bring it to the public. So the first case this is a case from yesterday, and just to kind of show you before and what I did. But the question is, what would you do in these kind of cases? So this is a 43-year-old woman who her implants are 7 years old, and she wanted to be a little bit bigger, but she didn't like the fact that she was so far out to the sides. And if you actually saw her laying down, her implants were really in her armpits. So the question is, how would you approach this? And you look at the distance from her nipple to her clavicle, it's pretty long. It makes her waist look a little bit shortened because the implants are pulling down a little bit. So the question is, how would you guys approach this? You can see what I did.
So the first thing is I want to find out to what extent the patient wants to be larger. Then you do specific measurements, what we've talked about before, her base width, to see what size diameter implant would work best for her body. I want to know exactly what she had in there, what profile it was, because my goal would be to, number one, to correct the pocket, the lateral displacement that she sees. There's a little bit of inferior lateral displacement, which can be repaired with a capsulorrhaphy, which can be done with a combination of techniques, including sutures or thermal or popcorn capsulorrhaphy. And depending on the thickness or thinness of her tissue, I'd also want to consider using some internal support through some type of bioabsorbable material like GalaShape, GalaFlex, or GalaForm. So the combination of those things would help to improve the implant pocket, as well as increase the base width of the implant we're using, the profile. The other question becomes, if you are not able to put an implant wide enough to correct the space between her cleavage, then you might want to consider doing a composite augmentation and using some autologous fat to layer the fat along the transition zones, along the medial cleavage and the upper pole of the breast, to soften that upper pole border, as well as give her some more volume through just a soft tissue enhancement medially.
So she had, just to follow up with this, she had 7 years ago, not by me, areolar incision, a 425cc high-profile implant placed submuscularly.
Right, so now you have a high-profile implant, which means that you have a smaller base diameter with more projection. So you can actually increase the base width using a similar projection implant and not going up significantly in volume. So now what you've done is you corrected the shape of the breast by adding an increased base diameter with the similar projection, so you get more upper pole fullness with that more cleavage. Now, because she probably has some laxity from displacement of the muscle over time, I would go in and do the capsulorrhaphy, and then based on her thinner tissues, use the GalaShape too.
Anup, what do you think?
I agree with the thoughts that have been put out by Charlie. I think that if you're going to upsize to a bigger implant, you need something to support the weight of the extra implant. So using GalaForm would be a reasonable option. In addition, I think you have to tighten up that pocket laterally so it doesn't displace out there, and you could use that with the combination of the GalaForm. And then I think if you're still worried about getting medial correction of volume there, adjunct of fat grafting would be a viable option. And it looks like whatever Jason would be interested in hearing what he has ended up doing, if he did use fat or any biomaterial.
How about Bill? What would you do?
I don't disagree. I think this is the interesting thing about this is a typical thing that we see. Even though you hear a lot of noise about, ALCL, other things about breast implants, this is the thing that we see every day, all the time. And these are the type of things that patients want to know about. So, yeah, I would do something similar to what has already been detailed by Charlie and Anup. I think that using some sort of soft tissue support oftentimes in these cases is really a valuable adjunct to really kind of support that result. And I think Charlie's point about the high profile implant changing the height, you don't really need projection, you need height and width in order to restore good breast shape, and going up a little bit in the size if that's what she wanted. She probably will do quite well. I'm sure you did a great job, Jason.
So let's go back to the patient. I'll just a little bit on my thinking process. So the question is, why did this happen? So the reason, in my mind, either the surgeon at the time dissected too far laterally and there fell to the sides, or they didn't release enough muscle medially, so she had 7 years of these pec muscles pushing them to the outside. One of those two things, or a combination of both. So when I go in there, I opened her up. I opened the pocket superiorly and medially and released a little bit more muscle. Because if you want to push those implants up and you don't release the capsule superiorly, there's nowhere for the implant to go, and it's just pushing down on you forever, and it's going to pop again. The second thing is, laterally, her tissues were pretty crappy. So what I did was, her capsules were soft. I heard Pat Maxwell talk. We were living a talk one day we were talking for some Stratus and Alloderm, and he said something that stuck in my brain since that time I heard him talk. He said breast implant problems can go into one of two categories: too much scar or too little scar. So in this case, too little scar, too soft tissues, pushed to the outside. So I did popcorn because I don't think shiny stuff and shiny stuff will stick together. So I like to popcorn it. And then I used a quill suture laterally to bring her in. And I thought that wouldn't really hold because the tissues were pretty crappy, even though I did 3 layers. I put a sizer in, and she wanted to go up, so I chose to go with another high profile implant, because I thought that given my repositioning of the lateral tissue, the high profile looked good. But I thought that I had to put some mesh in, otherwise it wouldn't have held. So I used Galaform in there, their 3D mesh, sewed it into place with a couple of sutures, and then I used a 520 high profile Allergan implant. And that's what she looks like on day 1.
So I have another couple questions. First,
today.
With the Allergan implant, did you change the cohesivity? Was it an SSF?
It's a good question. I used an SR. This was an SRF.
Okay.
I do like I didn't go, if she was really thin-skinned, I would have gone for an SCF, but I used an SR. I don't know. I go back and forth between SRs and SFs.
Right. I think that's an important thing to talk about with patients, because there's different levels of cohesivity. You're talking about Allergan's implants. They have the responsive, the SR. They have the soft touch, the SS, and then the highly cohesive SC. So as you increase the thickness or the cohesivity, they're going to potentially either give you less wrinkling or rippling and more maintenance of the upper pole volume, especially when someone is lying down.
What are you using? Which ones do you like?
I use most of the responsive, but in a case where the patient has thin tissue, I like the soft touch because I think it's got enough cohesivity to be to maintain its shape and fullness, but at the same time, I find sometimes the SCM, the SCF, is a little more rigid in a thin skin or thin tissue patient. You can sometimes actually feel the implant edges a little bit more. So I personally like the soft touch if I did my choice.
What did you use to hold the Galaform in place?
Two of
Or did you not?
Vicryls, a couple of them.
Now, I know Bill, I think someone told me, one of the reps from Gala Shape told me that, and Bill, you said this, when you put that Gala Shape in there, if you have the implant in there and you kind of layer it in, it just stays right where you put it. It grips the tissue, and depending on how many sutures, or you don't even need to suture, it'll hold right in position if the implant is kind of pushing it right against the capsule, right against the.
Yeah, I mean, I think the key is that number one, you want to get it against some sort of vascularized tissue. So if you're putting it in like a newly dissected pocket, like in an augmentation mastopexy, you can put Galaform in, no sutures, and you're done. It's 95% incorporated in 7 days. It's bolstered in place by the implant. It's not going to go anywhere. Now, in this case, what I would do is I would do a little capsulotomy at some point behind where the P4HB is, and that will fully incorporate. And you can decide what you need to do. The good thing about that material is you really don't need to put in a lot of fixation, unlike ADMs, which really relied on the suture fixation for the support, which is different from P4HB, which the material actually is a support. So, well, listen, that's great stuff. let's get on to the topics. So Anoop, let me start with you. So this first one's on this interesting new technology, eye tracking technology. We actually have visited this before in Plastic Surgery Channel. Dan Delvecchio was on, and he was talking about buttock augmentation. He was saying that there's this thing called eye seconds, which is how long people's eyes will kind of flash to somebody's buttock. And there was some data to suggest that people that had buttock augmentation had longer eye seconds than somebody that didn't. But this is about breast reconstruction patients, and they're using this technology to kind of perfect and make the reconstructive result better. So what are your thoughts?
I think this study was kind of a piggyback on the one that came out of Stanford, and it was kind of trying to find out what are people noticing, not particularly volume of the breast, but they were focusing on a lot of the asymmetries like scarring around the nipple. I thought this was it was an okay study, but it's definitely intuitive, and it's tracking what things bother the aesthetic eye. It's sort of an unbiased thing. You put the glasses or the eye watch on this person, and then it just tracks their movements of their eyes and seeing and timing how much of their eye is spent on that particular feature of the breast. So it's kind of innovative, and it was seemed like a pretty fun study to read about.
Yes, definitely fun. Charlie, what do you think?
I think eye tracking doesn't necessarily, from my perspective, mean that something is more attractive. It catches your attention. Like Anoop mentioned, they looked at the scars. So if you have worse scarring, it doesn't make the breast necessarily attractive, but it draws your attention. Or if you have significant asymmetry, that's going to stand out. I think that the
You're a big
concept.
mole. You got to look at your mole.
That's right. The concept is that we're trying to identify what is aesthetically pleasing to the eye. So using eye tracking technology to say, okay, if your eye looks at this particular area for a long period of time, it must necessarily intuitively mean it's more attractive. But I think everyone, there's a certain set of standards for breast aesthetics, especially that Dr. Malucci's kind of outlined in his work. And we use that, but everything is up to the individual patient and the individual person looking at someone's breast or whatever body part it may be. Dan's comment, if someone has an overly augmented buttock, they look at it not because they like it, they look at it because it looks strange. And I see that a lot in South Florida.
Jason, last time I went to the beach with you, you had a lot of eye seconds, so you must have a lot to say about that.
Like, you guys are discussing this with a straight face. Somebody funded a study that somebody else could look at porn and watch their eyes while they looked at porn. I want to know who funded this study.
Dan Delvecchio.
Dan Delvecchio, right? Like realistically, taken a bunch of 16-year-olds and done the study for free.
Right.
They look at this all day long.
Yeah.
So, I mean, I have no idea. Honestly, I read this study and I'm thinking, I have no idea. If you show me a nice pair of boobs, I can tell you if they look good, but I can't really tell you what separates one good set from another set. But listen, we've all, on a serious note, we've all been doing this for a long time, and sometimes we can't put into words what our eyes and what our perception shows us. If any of you guys look at a set of breasts on a patient, you know immediately whether they're sitting pretty, sitting not, and what the problem is. And maybe we need studies like this to be able to figure out the proper proportions, so we can actually teach people so that who don't have our level of experience.
I think bringing in pictures is a great idea because it at least gives you a baseline of this. Whatever they're asking for is at least achievable. And if it's out in left field, that's not going to be a patient that you're going to be able to make happy. And going back to the case that you just presented, Jason, I think if you had eye tracking on, everybody in this panel here would have basically seen how the eyes had tracked to the lateral displacement of that implant. So as was discussed, it doesn't necessarily mean that that's a good thing, but we do pick up the asymmetry or the unnatural breast because that breast was so laterally displaced almost into the back.
All right, this is a great comment. So the second topic, Charlie, let's start with you. This is actually a lawsuit on a plastic surgeon in Canada that allegedly was taping patients during consultations without their consent. So the first question is, have you comment on that? And then also, if you guys want to comment just on the flip side, because one thing is there's a debate about patients wanting to tape their consultation at the doctor's office. So Charlie, what are your thoughts on both of those?
My first statement is that I have video surveillance in my office in the common areas, meaning where people are exchanging money, where the office staff is entering phones, where they're entering and exiting the building. And I'm required by law to have a sign that says there's video surveillance taking place in the office. So I think videotaping with a sort of a hidden camera, so to speak, in an exam room is not appropriate. Not unless you have the patient have a verbal consent, a signed consent, that we're going to be videotaping this entire consultation, because the patient is going into the exam room, they're undressing, they don't know they're being videotaped. The other thing they brought out in the article was that there was a patient and her friend together having a private conversation, which they didn't realize was being videotaped. So I think it's very important in anything we do, using photographs for advertisements, photographs for our website, for social media. You need the patient's consent, especially nowadays, when there's so much availability of personal information on the internet. If you put pictures out or photos out without their consent, they could really kind of upset someone, especially with the delicate, sensitive information and materials we're dealing with here.
Well, I think that that this doctor is a social media phenomenon, doing all kinds of crazy things, but this may be his sword that stabs him, because you cannot record a patient that's naked and nude without their permission. That's just egregiously wrong. And if you turn the tables, none of us would want that when we're in a doctor's office being recorded and monitored without any information. Some of these things that people are doing on TV and recording is just for pure sensationalism. On Instagram, there was a guy, I think, a dentist, trying to pull a tooth on a hoverboard that basically is going to court. And I don't think this guy will have a leg to stand on. I mean, if you're
just a hoverboard.
But those are my thoughts.
So, what about patients that want to record a consultation? What do you think about that?
I think that's also a slippery slope. I think that it depends from surgeon to surgeon, but I in my opinion or my perspective, I would not go for that route. I would definitely just reiterate that the patient could come back and have as many consultations as they want. Of course, if you charge a rate, they'd have to pay that. But recording a conversation and then them having that and taking you, I mean, it's just, I think it opens up the surgeon to a lot of issues.
Jason, what do you think?
I'm going to agree with both of these guys, and the issue is, we've discussed this in the past on NoSpin. These social media guys, their primary goal in life is to just record things and be on TV and become popular icons. And the issue is that they don't know shit about surgery. They don't spend the time to learn how to do surgery. They don't want to do surgery. They just want to be on TV. And I think the thing is, we're all serious people. Our livings are made in the OR. We want to perfect our craft. You want to do the best thing possible for the patients. And if you're filming people and doing all this other crap during cases, you're not spending your attention on the patient, and it's just criminal to be recording people without their consent. That's like having TVs in the bathroom or locker rooms. You can't do that. That's insane.
All right, Team Florida, full throttle. That was great stuff. If you want to see more of this, you can see it on theplasticsurgerychannel.com.